Participants Taylor argues for vaccination mandates. Jordan argues against or urges strong caution. Taylor: let me start with the practical outcome. When jurisdictions adopt vaccination mandates, especially for school entry, universities, or healthcare settings, coverage rises. We've seen it repeatedly. Tightening exemptions or requiring proof for certain activities moves people who are on the fence to get the shot. Higher coverage then translates into fewer outbreaks and less strain on hospitals. Jordan: that's part of the story, but not the whole story. Mandates can also trigger backlash, deepen mistrust, and push some people away from the health system. If the goal is sustained public confidence, a policy that wins short-term compliance but hardens long-term resistance might not be the win it appears to be. Taylor: backlash gets attention, but we should weigh population effects. In schools, stronger entry requirements consistently correlate with higher immunization and fewer disease clusters. In hospitals, linking employment to vaccination protects vulnerable patients. On university campuses, mandates during waves meant fewer cases, fewer disruptions, and a quicker return to normal operations. Jordan: you're assuming the externality is always large. That's not guaranteed. When vaccines are superb at blocking infection and transmission, the externality, and thus the case for mandates, is strong. But when variants reduce that transmission blocking effect, the public health logic shifts toward personal protection rather than source control. In those periods, broad mandates may offer less societal gain while still carrying social costs. Taylor: even with variants that dent transmission protection, vaccines still sharply reduce severe disease, hospitalizations, and deaths. That benefit isn't purely private. Lower severe disease reduces crowding in emergency rooms and ICU units, preserving capacity for everyone. And mandates are most commonly applied in places where the stakes are highest: healthcare, schools, and crowded settings. Jordan: we also have to consider workforce dynamics. In some hospitals and long-term care facilities, strict enforcement produced staff exits and short-term shortages. If a policy to protect patients ends up reducing staff levels enough to impair care, the net effect gets murkier. The reality on the ground varies by region and by how thin staffing already is. Taylor: which argues for designing mandates well, not abandoning them. Include paid time off for vaccination and recovery. Offer on-site clinics. Provide clear, limited medical exemptions. Pair the rule with communication and easy scheduling. When the friction is low, acceptance rises and attrition falls. Most places that implemented thoughtfully saw coverage jump without lasting staffing crises. Jordan: design matters, sure, but mandates also interact with trust. For people who already distrust institutions, a mandate can feel coercive. That can spill into other health behaviors. Fewer checkups, less willingness to heed future guidance. If the long game is a resilient public health relationship, there's a risk here. Taylor: public policy always balances carrots and sticks. Seatbelt laws, smoking bans, drunk driving limits, all faced pushback but delivered big safety gains. Vaccination is similar when the evidence shows large reductions in harm to others, and mandates aren't the first resort. They usually arrive after months of open access, information campaigns, and voluntary uptake. Jordan: there's also an equity angle. Documentation requirements and appointment scheduling can penalize people with hourly jobs or caregiving duties. Without guaranteed paid time off, the cost of compliance is higher for the least advantaged. That's perverse, especially if penalties restrict access to work or education for those same groups. Taylor: agreed, which is why good policy packages must include supports: paid sick leave, flexible hours, transportation vouchers, mobile clinics, and multilingual outreach. When you remove those barriers, you're not just making mandates fairer, you're improving voluntary uptake too. Jordan, another question is scope. A mandate for hospital staff who interact with fragile patients is very different from a broad mandate for all indoor public spaces when community risk is low. The former has a strong ethical case. The latter can overshoot and breed resentment. Taylor, scope should reflect risk. High-risk settings justify stricter rules. Low-risk settings might use certificates seasonally or not at all. Time-bounding matters too. You can design sunset clauses or periodic review thresholds, say ICU occupancy, variant severity, or vaccine effectiveness against transmission, to ratchet policies up or down responsibly. Jordan, communication is crucial. If the public hears mandates forever, they'll push back. If instead they hear temporary measures tied to public metrics, that's easier to accept. It also forces policymakers to show their work. What benefits are expected, what costs are tracked, and when the rule will relax. Taylor, I'd add that mandates can be a signal. They tell risk-averse people, immunocompromised patients, families of kids with medical vulnerabilities, that society is taking their safety seriously. That has value beyond the raw epidemiology. It enables participation by people who might otherwise stay home. Jordan, there's a counter-signal too. To those already skeptical, mandates can validate a narrative of overreach. For them, outreach through community leaders, clinicians they trust, and transparent data often works better than rules. If a mandate is imposed without that groundwork, you can entrench opposition. Taylor, so we converge on a design principle. Mandates work best as part of a bundle. Easy access, paid time off, clear communication, limited exemptions, and careful scoping. In those conditions, the benefits, higher coverage, fewer outbreaks, protection of healthcare capacity, are large, while costs are manageable. Jordan, and I'd add a second principle. Be conditional and reversible. Tie mandates to metrics, hospital load, variant severity, and vaccine performance against transmission. When those metrics ease, step down the policy. That makes the rule feel fair and evidence-based, and it reduces long-term trust damage. Taylor, what about children and schools? The evidence is especially clear there. School entry requirements have long histories and strong outcomes. They're a backbone of childhood immunization. Jordan, schools are also where fairness concerns are most sensitive. Kids shouldn't be excluded lightly, and families differ in constraints. Again, supports matter. School-based clinics, culturally competent outreach, and simple, well-defined medical exemptions. If the rule is predictable and assistance is real, compliance is high without punitive effects. Taylor, in healthcare, I'd keep mandates firmly in place during respiratory virus seasons. Patients in chemo wards or transplant units can't protect themselves fully. Staff vaccination reduces the risk they face from routine care. Jordan, I'd keep a narrower lens. Mandate where patient risk is truly high and staffing capacity can absorb attrition. Use frequent testing and high filtration masks elsewhere. That still protects patients while maintaining flexibility when the externality is smaller. Taylor, perhaps the end game is not binary. It's a calibrated toolbox. Mandates for the highest risk settings and periods, certificates or testing options in medium risk contexts, and purely voluntary strategies where risk is low. Each lever activates based on transparent thresholds. Jordan, I can sign on to that, with the caveat that every lever should come with supports that eliminate avoidable burdens on lower-income workers and caregivers. If the system asks people to do something, it should make that thing easy and affordable. Taylor, then we're aligned. The core empirical reality is that mandates raise coverage and reduce outbreaks, especially where the stakes are highest. The core ethical reality is that they must be justified, supported, and temporary. Jordan. And the core political reality is that trust is finite. Use mandates when they clearly deliver net social benefit, explain the rationale in public metrics, cushion the burdens, and step them down as soon as conditions allow. Taylor. That's a policy mix I can defend. Jordan. Me too, provided the evidence keeps guiding when and how we pull those levers.